All right, well, we're coming up here at 1 p.m. Eastern time. So again, hello and welcome to everyone who's joined. I'm Liana Edwards, the lead for logistics and design here at CFHA, filling in for Tanya Latter, who's our co-facilitator for our community conversation. So yeah, just wanted to say thank you for taking the time out of your day to participate in this conversation. I think it should be a very good one. And with that, I'll pass it off to Corey, who's gonna get us going.
Hey everyone, thank you for joining us today. My name is Corey Knight. I'm a second year doctoral candidate in health service psychology at the University of Houston, Clear Lake. And so as part of our ongoing series of community conversations, about 2 or 3 months ago, the Myths of PCBH idea kind of popped up. And we really decided to run with it just because for most of us here who either work with the model, have previously worked, or just have some sort of interaction with it, there's been a lot of different things that have been said. And some of them may hold more truth, some not so much. And so what we really wanted to do today was have a conversation around some of this. And a lot of what we have is pulled from the listserv. So I want to thank everybody who contributed to that, really had some excellent points. And so today we're going to break it into kind of 3 sections. We're going to talk a little bit about the billing level, kind of like the provider level, and then some myths that a lot of trainees may hear or say just based off a few of the things that they've experienced. I do want to take a chance to thank our wonderful super participants today, William Summers and Megan Fondow. So they're both going to help fill us in on some of this. I do want to say as well that I am going to try my best to monitor the chat just in case anything else comes up too. With Zoom, it's kind of tucked away at the top, so just bear with me as we go. All right. So let's start off with the billing myths here. So this was a big focus of the listserv conversation when we had put this up. And so I think this would be a really great place to dive into. William, Megan, whichever of you all want to kind of take a stab at this first. So really the first big one there is you can't make money for the clinic. And I imagine that'll kind of tie into a couple of these other ones as well. So whichever one of you would like to jump in first would be great.
Yeah, I'll jump in. So y'all, my name is Will Summers. Just a quick background on me. I finished my doctorate at George Fox University in 2020. I did my internship at Central Washington Family Medicine in Yakima, Washington, where Dave Bauman and Bridget Beachy are, if y'all are familiar with their work. I did my postdoc there at the pediatric clinic and then moved to New Jersey last year and found out 2 days before I moved that New Jersey requires 2 years of a postdoc. So I'm doing postdoc part 2 over here in Jersey, getting the rest of my hours. I'm at a private practice clinic for now. So hopefully that'll give me a unique perspective. And towards the original question, as far as making money for the clinic. So like I said, I was at Central Washington Family Medicine for the last couple of years. And I was there before COVID. And then when COVID came upon us out of nowhere in 2020. And so I had the opportunity to be in my postdoc year and talk with Dave Bauman and Bridget about the department-wide financial concerns in the context of COVID. And throughout that whole time, the BHC, Behavioral Health Department, was the only department consistently making money. Others were, it sounded like they were a little hit and miss. So certainly the transition into telemedicine and that our jobs can be pretty well done via phone visits aided to that. So even in COVID, with all the craziness that was 2020, 2021, behavioral health consultants still made plenty of money for the clinic in my experience. So, go ahead, Megan.
Thanks, Will. Yeah, I'm Megan Fondow. I'm a behavioral health consultant psychologist at Access Community Health Centers in Madison, Wisconsin. Been doing this for about 15 years. Don't want to ever do any other kind of work. So there you go. I think that there's a lot of myths, yes, associated with billing in a lot of different ways. And I appreciated the really lively conversation on the listserv as well. It was really fun to see all the different reactions from people. And I would say for the first one of you can't make money in the clinic, I don't think that that's true. I also encourage programs to not set themselves up to that they have to make money to be able to sustain themselves, if that makes sense. So trying to kind of balance that out. There are sometimes where folks are able to take advantage of a grant to get started with a program, which is wonderful. And then if they're not able to get to the point where things are evening out, then that can make it hard to continue if the grant funding goes away and administrators don't quite understand the logistics of how all of it goes together. So I think it's more complicated perhaps than just a yes, no question. And I'd love to hear opinions from others as well, if there's others who have thoughts on this issue too. That's where I would stop there.
I would just say that I work as a behavioral health consultant. I'm a clinical social worker in Newton, Kansas. And when we first started the more integrated care model and hired BHCs, there was the thought that we're not going to bill, we're not going to, I mean, it was an intentional decision not to bill and knowing that the BHCs were not going to bring in money for the clinic. But after doing it for several years, we now bill. And what Will was saying, during that first year of COVID, our BH numbers went up while the medical numbers went down. And so that was also a really good, I don't know if I'd call it eye-opening. I think we were aware, but yeah, my BHCs bring in quite a bit of money for the clinic.
Go ahead.
Okay. Hi, this is Laura. I think where my mind goes on this particular bullet point is that oftentimes clinics that I've worked with don't have their own integrated behavioral health budget. And when you look at like FQHC environments where a lot of the work of the BHC is getting bundled under the primary care provider, and there's the prospective payment or the wrap payment, like it's hard to sort of see what money is coming in because of the BHC, because it's more of a global budget. So that's some of the nuances that I've seen that have been hard to kind of make that statement, say, yes or no to that statement.
That's a great point, Laura. I totally agree that it's complicated to parse it all out depending on how the revenue streams are coming in and how the departments are set up, which is also why it's helpful to just continue to have a hopefully friendly relationship with not only your coders, but also your accounting teams as well, to just have conversations, right? To just continue to learn and understand where all the dollars are going and where they're coming from, and making sure we're capturing everything we can and all of that as well.
I was going to add that it's also important to consider the subtle ways that behavioral health departments help make money for the clinic. And maybe not directly so, but even taking a warm handoff and letting a physician get out of the room closer to their alleged, next patient coming in, instead of letting them stay in for 45 minutes talking to someone when they're 3 patients behind, obviously helps the whole system flow better and makes money, even if it's not as directly as bringing in cash, especially in Julie's case where they weren't billing directly for services in the beginning. So yeah, there's subtle ways that we make money as well.
That is a great point. I think that it also brings to mind the ways that having BHCs integrated into the clinic can help reduce the burden on the providers just overall, right? That example is a perfect example of it. And I think it can really help decrease burnout rates for your providers as well, which is going to decrease turnover, which is going to also be another money saver in the long run too. Those are, again, much more diffuse and a little bit harder to track for numbers, but can be helpful to keep in mind.
We now have providers who will say directly, we don't know how we did our job before you all came. Yeah.
Yep, I've heard the same. Like, I never want to work without you guys. That was a big thing during the pandemic. We were sort of not as on-site, not as integrated, right, for a while because of just how things were working. And we were still around, but it was different. And even just being in a room down the hall instead of sitting right next to somebody made a difference. And once we got back into the shared spaces again, providers were like, this is so much better. So that visibility is a big part of it. And it's always surprising to me how big of a difference it makes, even just being literally next door versus right in the same room.
Yeah, I mean, that's really great, just because we're hitting this from like a direct and indirect perspective, right? So we have this moment where we're directly contributing revenue, but in an indirect way, we're helping clinic output, we're saving providers time, like we're essentially saving money on the front and back end. And so I think this is great. And, for me, like my mind kind of goes to the direction that I wish this was sometimes more easily translated to people and really understanding, hey, this is what we bring, to the picture. And I think some of this gets lost, unfortunately, in the day-to-day operations, or maybe even for people who don't really understand how BHCs can help fund structures or the money that they can help save. So I think those are excellent points. And I think that's something we definitely need to touch on as well. I also see a comment, yeah, that's from you, Laura. Laura, value-based payment. Yeah, so and I think we're going to keep going through a couple of these because I see some overlap with these. And so I think these next 2 points, you can't bill for 30-minute psychotherapy codes, and you can only use health and behavior codes. I think those two might kind of tie together. And so Will and Megan, if one of you want to start talking about that, that would be great.
Sure, I can chat about that a little. It's an interesting myth because I think it's just not true. So we can do the psychotherapy codes, we can do the health and behavior codes. I think always looking at your local rules, your local coders, your state rules, depending on degree type and all that, because there is some variability across the country for some of these, which may be where some of the myths come from, but they are certainly not true blanket across the board for the whole nation.
Yeah, and I don't have too much to contribute here. Just like Megan said, it just seems pretty outright. Like I didn't know that was a question or a myth that is well circulated. I've never been in a practice that said either of these myths, so I don't have too much to add.
Yeah, well, I'm wondering too, just looking at the chat here, because I'm seeing a couple of comments pop up. So for Tanya put for South Carolina, they can't bill Medicaid. They will not reimburse without a full treatment plan for a psychiatric diagnostic assessment code. North Carolina struggling to find human bodies to fill rural clinics due to money billing issues. And so I think this really also helps us understand too how much this differs by region, kind of what Laura was saying earlier, how some of these challenges with billing run from state to state. Because I mean, the settings I've been in so far myself, I haven't seen too much pushback, but it seems like there are some real challenges for what we're seeing around the United States from region to region. I'm wondering if any of our other participants in this call here have any feedback on this or can share any insights of their own.
I put it in the chat, but in Kansas, we don't get paid for the health and behavior codes. And so we tried for a while to use those in the situations where there wasn't a diagnosis, like obesity management. You're not going to get paid with a psychotherapy code for that. And so we tried using the health and behavior just to build a case for why we should be getting paid for those. But our billing department got kind of cranky with us. And so we kind of had to let that go, at least for now. But I would also say the other comment I saw was the difficulty in finding bodies. I'm having a terrible time hiring clinical people. I don't know what it's like in other states, but in Kansas, our clinical level people are all putting out a shingle and going into private practice.
Yeah, and I think I think it's on some of the further the upcoming slides about some of the talk around why it's hard to get people into primary care. And again, I'm someone who was in primary care the last couple of years, and then this year I'm in private practice just as needing my hours. So once we get there, I can talk a little bit about why some of my colleagues would be hesitant or reluctant to take a job in primary care.
Well, I'm looking at the chat too, because we're starting to get a little more active as we go through this. Yeah, I mean, that seems to be the common consensus. Definitely some real challenges hiring. Laura, I saw your comment too about the carve out for using those billing codes for specialty mental health as compared to like behavioral health consultants, for example. Let me see. Yeah, so I mean, and I think this is going to be a good area as we transition to the next slide. I do want to touch on, though, this belief that around a full mental health assessment, because I think this is really important. As psychologists, for example, traditionally taught have to have this very in-depth assessment plan, numerous assessments, could take anywhere from 1, 2, 3 sessions, depending on the severity of the problem, the referral problem. However, I know within primary care, we don't have that luxury a lot of the time. And so I'm wondering, Will, Megan, anyone else on this call, your experience with more of a full mental health assessment versus the type of assessment you do in primary care?
Yeah, that's a good question. And I appreciated the chat on the listserv about this as well, because I think one of the things that I always want to know is what do we mean by a full mental health assessment? You know, I think it sounds very magical. And I think that also thinking about what are we actually looking at? What is the goal of this? What is the purpose of it? And then again, in terms of coding, what are the coding requirements, right? What are they actually looking for to use certain codes? What has to be in the note? That can be part of what you're looking for as well. I think that sometimes when people say the words full mental health assessment, that isn't necessarily what they mean. So that's a lot of times where I start, particularly if it's a patient coming in and saying that's what they need is a full mental health assessment. Okay, tell me more. What is this for? What is the goal? You know, because we can often do a lot to help people. And it may be that what they need is not a full, huge, long 3-hour ordeal, right? So.
Yeah, and to piggyback off of that, as somebody who's now in private practice, like I keep saying, my first visit with somebody commonly, sure, I do my pretty much the same intake I was doing in primary care, which again, I can do certainly in 30 minutes or less, probably about a solid 10 to 20 minutes, and still save time for talking about presenting problem, coming up with an idea. But even in the private practice setting I'm at now, I'll have that first visit where I do talk about, love, work, play, the contextual interview. And then after that, the majority of our visits are typically about functioning and presenting problem material. It's a lot less about any of the intake information. So the only time where I would spend more than 30 minutes on a mental health assessment is if someone is very particular and direct that they need, like that they're wondering if they have depression or PTSD or have some sort of very specific diagnostic question. But again, that's very rare, and I can only think of 1 or 2 cases in which that's been the case in this entire last year for me.
Yeah, I think the only thing that comes to mind to me is specific cases where people are asking for a certain kind of evaluation, right? That they're trying to build a case for disability. That's one thing that we can help with in terms of records along the way, versus an evaluation for their fitness to be a parent in a custody hearing or something like that, right? So depending on what it is, if it's something really specific like that, we may have a different line just because of the very nature of what they're looking to get support on. It just might be out of our scope of what we're able to do. So again, I think those conversations with the patients can be really helpful.
Well, I know as we're talking about this, one thing that comes to mind also is things like bariatric surgery evaluations as well. That can be another really important one where we need more of a comprehensive assessment report, or even something where there's a lot of chronicity to it. And we really have to make a strong differential diagnosis and really try to understand if we have to hone in on something to focus on, what might that be? And yet I really appreciate kind of the depth of that, because the reality of this, kind of Will's point out, Megan, you're pointing out as well, is that we can get so much information so fast. I mean, and I love the contextual interview. That's one of my go-tos, even within traditional hour-long 50-minute sessions. It's really phenomenal just because I know for me, that gives me a lot of really great information, and helps really guide some ideas for intervention and some collaborative treatment plans that I can work on. But I think it's a good point. We can get a lot of really good info. And I mean, do we need that comprehensive evaluation? I think that's very much on a case-by-case basis.
Yeah, I think the only other comment I would have on this too, to build off of that, Corey, is like going off of some of the stuff I saw going through the chat, is it can be helpful to think about ways to advocate for changes in the codes as well with your local legislators, state legislators, Medicaid people, whoever it is that is the roadblock or whoever can help make things move forward. That takes a lot of time, but it can be worth it in the long run if we're able to make some changes to expand things out. So the telehealth for our state in Wisconsin was one of those where initially it was approved during the pandemic for temporary use, and then eventually it was approved for permanent use for physicians, but not for behavioral health. And then eventually they got on the parity bandwagon and got that amended as well. So it was good.
Yeah, thank you for that, Megan. I mean, I think there's some really good points here. I'm taking a few notes, and I think these will be good things to also bring back to the higher ups and possibly have some ideas around this for the future as far as, maybe a repository for billing codes or understanding maybe some of these differences and hiring. I know we have our job posting forums as well, but yeah, I think that's a really good point is we always, sometimes we don't think about the power of advocacy. And at the same time, we run into how do we do it? And so I think that's a really excellent point. And I know just here in Texas, we were having some challenges with telehealth billing. And it's, I don't know, there's still some things they're getting worked out, but I know advocacy is extremely, extremely important, especially with everything we're going through right now and figuring out the coding situation. So yeah, I appreciate that point. I think that's something that might be an idea for something, a future endeavor in CFHA. Let me see. I'm also trying to keep a look. Well, I really appreciate the dialogue too. I'm looking at the chat box and people are just having at it. So that's good. I'm glad to see that today. All right. So for the sake of time, I want to get into more of some of like the broader scale practice myths, because I think these are things I know early on in my training, I heard, and it's kind of interesting. And just even my own experience within integrated care, these are some of the biggest myths I continue to hear. And I have to do a lot of psychoeducation around these. So let's start off with that top one. You only provide care for small problems and really just conduct crisis management services. So what are y'all's take on that?
So one of my colleagues during my internship here, her quality assurance project was, quality improvement project was to see the effectiveness of treating PTSD by using prolonged exposure and CPT and other manualized treatments in a primary care setting. And I think she had an N of like 8 people that she was seeing at one of our clinics. And the outcomes were pretty unanimous that people benefited on all the measures. And again, she was talking about PTSD stuff, some narrative and exposure therapy. And those are like, obviously like big problems and, compared to small problems. And so I certainly think that it does great for small problems. And then as far as crisis management, we do more than that as well. One thing I love most about primary care was, sure, there's some crisis management, but there's also, hey, help my 2-year-old eat vegetables. So I just love the big, broad, wide spectrum. And that's something I dearly miss in private practice, that everyone comes here for anxiety and depression, which is great, but I like talking about making kids eat vegetables too. So yeah, certainly a myth that I would say is debunked.
I would agree. I don't even know if I can count the number of times I had a comment like this, or the other version of it that I've heard is you just triage issues to get people connected to other services, other places. And I think all of those are just oversimplifications, because we do all of these things, right? We help with everything. And I think when I've tried to share with people about what we do and help them to basically build a box in their mind, right? A conceptual box for this kind of work. That's one of the things that I highlight, is that we're trying to match the generalist nature of the work that the primary care providers do for behavioral health and substance use services. And then also, of course, connecting people to specialty care as medical providers connect people to medical specialty care when that's indicated or needed. But we can do a lot in primary care. We can do a lot. And not only helping in acute situations, but also helping with more significant psychopathology and also the more mild things as well, or the psychoeducation, which are some of the fun visits as well outlined, getting some psychoeds for parents on why their kid is abruptly throwing tantrums. Well, that's the stage they're at, right? This is a normal part of development. So let's talk about this. That's really satisfying as well.
Yeah, and just to add to that, because I think those are some really great points. And if we think about it too from like the research side with some of the dissemination studies that have been conducted, and we look at the different components of treatment packages, that sort of thing, a lot of it breaks down to just like simple skills and simple things we work on that don't take a ton of time to work on, yet they can have the biggest impact as well. So I'm wondering, some of the other individuals that are on this call, what has been your experience been with this for treating things like trauma, for example, or maybe another complex issue? How has it been working within that kind of 15 to 30 minute time frame?
Hi, everyone. My name is Jacob. I've been working in primary care probably for about 12 years now, and I treat all sorts of problems in primary care. With trauma and some of the more complex things, I might not focus on really some of the exposure elements of treating trauma and more work with the patient on developing emotional regulation skills, using ACT techniques to manage their thoughts and emotions in different ways, which oftentimes I've had patients with PTSD, they take the skills and they're able to manage and their symptoms get better. But I try not to do the exposure elements in that 30-minute window. I don't want to open them up and then not have time to really help them process and close things down. But I will be working with them to get them to the point where they're ready to engage with someone in doing traditional care. And so that's the way you can help, is maybe not directly treating the problem, but how do you kind of help them with where they're at. I've worked with patients with schizophrenia. And again, it's not about trying to cure them. How do you help them manage? How do you help them get their primary care needs met? I've seen probably just about anything in the DSM. There's certain things like multiple personality disorder that is going to be longer term. But again, there was elements I could do in the primary care environment and get them over and connected into more of a specialty mental health setting.
I'll chime in real quick. My name's Melissa Welch. I'm currently in Florida in the Destin area, but I work in a couple of different clinics. Doing much more co-located care right now. We're building a family medicine residency program, and my goal is to eventually have it where we're much more integrated. But a lot of these myths are kind of the things that I'm working through to convince our FQHC that it's worthwhile. And so just trying to figure that out. But I know even in talking with our other mental health providers that we have who feel like they need more than an hour to work with a patient on things, and trying to convince them that a lot of it is just our time management and what we're doing in the room and how we control the session and make sure that it's being used wisely the whole time that we do have with them. Because I can get through a whole lot more in 45 minutes than some of the others can do in an hour and a half. And that's not to brag, it's just the skills that we're training and how we're doing it with our sessions. And so, helping them to understand what can be achieved in 30 minutes if we're doing it very mindfully and being very focused with our time. And I think that's important for us to make sure that we're addressing that when we're training our new behavioral health clinicians, to make sure that they understand how to do that, and trying to figure out how to make sure that's the priority, so that when we're with our patients, we're not just chatting about how the day was, but really making sure that we're being very intentional with all of the time that we do have with them. So that's just been something that I've been trying to be mindful of, and helping the others on my team understand that part too.
Hi, everyone. I like to chime in about this one too. My name is Teresa Rojo. In my role, I support many behavioral health clinicians working in pediatric practices, and we have a lot of clinicians working in a more collocated model, but we also have a hybrid way of working with some more handoff consultation time and then scheduled time for follow-ups. I'd say that the trauma question is, in part, we are talking about prevention, primary and secondary prevention. And as such, we are an ideal role to develop trauma-informed settings for patients who need to feel an environment that they can trust, and we are the first step for them to go to perhaps a therapist, because it's the first taste that they get of how that would look like. So easing them into their mental health specialty care is a very important aspect, as well as reducing the stigma associated with it and so on. So I think actually we are the best line of work for demystifying trauma and addressing it in the first line. And also someone else was mentioning, when it comes to treating the trauma, all evidence-based models are, before there is a trauma disclosure or narrative creation of a trauma, there are components that have to build the skills. So emotional regulation, distress tolerance, mindfulness, etc. And as well as psychoeducation for families. I think we also do that really well in primary care. So I'm all for saying yes to trauma.
I think those are such great points. I really appreciate you sharing that, because the trauma-informed care piece is a pretty huge one, in my opinion. And I think that we're well poised to be able to help not only do that ourselves directly with our work, but help the other providers in the clinic, right, to learn those strategies of how to provide the clear and direct communication of the care they're providing too, and providing choice as well. And I agree that there are times when we're helping to prep people for getting involved with more intensive trauma-focused therapy in the community. There are also times where I've had patients that don't want to do that, or at least not right now, right? That this might not be the right time for them to be engaging in that kind of more intensive work. And so that's part of what we can also do, is support their ability to have that choice and talk about that choice, and talk about, again, the skills that they need to help be able to live their lives and managing the symptoms that they have, and until they're ready, if they're ever ready, to go into more intensive therapy to work through the issues.
Well, and I also, I mean, I appreciate all the points that have been brought up just now, because we can have a huge impact in that 30-minute time range. And, that really depends on how we structure it, how we make the most of the time, and really how we set the tone for those visits. In addition to that, if we are connecting to trauma, like let's say community resources for trauma-based care or trauma-focused cognitive behavioral therapy, whatever that may look like, it's an excellent environment to work on some of those early skills for self-regulation. And I mean, it's great. I really appreciate the point of psychoeducation, and helping normalizing this kind of response, and helping people developing some rapport to help them feel that they can trust and work with somebody, and that they can continue to count on somebody as they go forward into these other services. And as we know, the literature shows that I think it's like about 20 to 30% of people actually go on to those community referrals. So that's another important factor that we have to keep in mind as we go through this. And I think this really ties into point 3 pretty well here. And this is something that, I mean, early in my training, individuals that I was going through school with were having some mixed feelings about. And basically, your services are not as good, especially mental health. And people can improve in just one visit. And, I don't want to rely on my own confirmation bias. I know this is a myth, because I've seen firsthand that this is not true. I'd love to hear Will, Megan, anyone else's experiences with this as well.
Certainly. And so, in Kirk Strassel and Patty Robinson's book, the modal number of visits that anybody has with a therapist is like a whopping 1, right? And so whether or not you believe people can or cannot improve in one visit, I think you're right. If you think they can't, they're definitely not going to. And if all you have is one shot anyways, why not gear up and truly believe, like, yeah, you can make a significant difference in one 30-minute visit. And similarly, Corey, don't want to rely on just my own hindsight bias, but even in the practice that I'm at now, I've regularly had people just 1 or 2 visits come back on the second visit and be like, it's been 2 or 3 weeks, but there's really not much more to talk about. Like, the things we talked about were good, kind of got me unwedged. And I think certainly at the end of the day, looking at improving people's functioning as like the Corey, telos of primary care can without a doubt be done in one visit. And my last thing I'd add is, thinking about my own self, I were to, a majority of my life, short of like really, really difficult chapters, if I was going through something tough, having some stress or anxiety, I think, yeah, if I could go and talk to somebody for 20 to 30 minutes, they were really empathic and attuned with me and had a couple of good ideas I hadn't thought of. Like, yeah, I don't need to go see somebody for 6 weeks straight because I'm having anxiety about a final exam coming up. So again, choosing my own self as a proxy, I think for a lot of my life, I would only need one 20 to 30-minute visit. So go ahead, Megan.
Yeah, I think those are great points, and I appreciate that. There was a comment earlier as well about single session therapy, which I think is completely relevant to this point as well. The second half of it, anyway, that people cannot improve in just one visit, because that's obviously not true, especially when you look at single session work. So I think that I have also definitely seen that play out where people do have quite a bit of relief and feel quite a bit better. I also think it's a bit of an oversimplification to think of it as just one visit. When we're having a warm handoff, we're riding on the coattails of the primary care provider, right? So we're already building on the relationship they have with their medical provider, which is not a small factor, right? It helps to get us in the door. It helps us to be able to build the trust and rapport even faster than we would otherwise. So I think that's important to keep in mind as well, is that we're able to capitalize on the patient's readiness and willingness to talk in that exact moment. And you're going to be able to make a lot more progress then when they're saying, yes, I would like to talk about this right now. Thank you. The first part of the statement that we're not as good as specialty mental health, that one always makes me want to compare apples and oranges, because they're just not the same, right? So that to me then brings up again the analogy of, well, then can you say that primary care is not as good as cardiology, right? Or neurology? Why would you make that comparison, right? They're just different. They don't do the same thing. They have different goals and they work in a different way, and that's okay. I think that it's actually great to have different modalities and different ways to do the work, because patients want different things as well, right? And then we're going to be able to hit on what works for more people if we have more ways to do the work.
Megan, to build off of what you were saying, just about changing how we're looking at it, I think for me, my goal has always been, how do we make this more like going to the dentist once every 6 months, right? Like, I don't need to go to the dentist all the time, but I need to go at least once or twice a year to make sure things are going right. And if I'm missing something, I need someone else to take a look at it and let me know that I'm missing that, make sure I can give that some extra care for a while. And just shifting our perspective from a reactive, oh my gosh, I need 6 months of therapy to deal with this, to a proactive of making sure that we're taking care of ourselves and checking in on that on a regular basis. So if I can help people shift their perspective and how we're looking at it, then it helps them to understand, okay, this model does make sense because we're not reacting in the same way we have been in the past. But it's easier said when you're passionate about it than convincing others who don't see it that way yet.
I really appreciate that. And I think that that's my new favorite analogy. So thank you for sharing it. So I think that's a wonderful comparison with dental. I love that. That's great.
Yeah, and I think there was, Melissa, I like that comment. I mean, I wrote that one down. I thought that was a great one as well. And I really think that hits on the importance of things like universal screening, for example, making this where every visit you have to the doctor, just kind of briefly checking in, seeing how things are going. Just like a PCP would, they'll walk into the room like, all right, what's going on today? How are you doing? This is just part of the treatment package, right? This is part of your, like, that total person-centered care. Looking through here as well, just on the comments, again, just another individual that's participating noted that a lot of times people go see their primary care provider over a specialty mental health provider, that their physician is their first stop when it comes to whether it's something mental health wise or maybe something that's going on in their lives. But yeah, I think the proactive approach is so important. And I think this really touches on something we've already talked a little bit about, but this is really important. You must use a particular theoretical approach to working in primary care. And I imagine many of the people on this call are familiar with CBT, with ACT, different problem solving modalities, that sort of thing. And so I'm wondering just, Will, Megan, or anybody else, what's been your experience with this?
I think that we use as many different orientations in primary care as probably they are used in private practice. There's probably some that we don't get into, but I think that's one of the beauties of the work in primary care is that we can draw in different modalities to be able to match what we're hearing from the patient. Whether that's motivational interviewing, CBT ACT, even some skills from DBT, some solution-focused problem solving, all of that it's just wonderful for us to have our own tools in our toolbox that we can then pull out to match what the patient is bringing to us and what they seem to resonate with, to be able to match what's happening.
Yeah, and I think primary care overall prides itself on its flexibility, being available, being accessible, being flexible, and certainly that does not end as far as what orientation people utilize. I've yet to meet a single other behavioral health consultant that would say you practice something closer to dynamic or interpersonal, so I don't think it's a good fit. I think they would maybe be open that there might be unique challenges, especially if you're a very classic psychoanalytic where you think like, hey, we need to meet 3 times a week for an hour, like might be some unique challenges in your practice. But I have a feeling most people here on this call and all of CFHA would say, if you want to try it, run some experiments, do it, but just please don't miss any warm handoffs,
And I think this also really brings up the importance of meeting people where they are. The referral problem, you may have 2 patients in the same day that may have a referral problem, maybe anxiety, depression, maybe diabetes management, but when you get them in the room, it can be very, very different. And the purpose of that visit may shift radically. You may end up having somebody who's in crisis. You may have somebody who maybe is not ready for dietary change. Maybe they need an exercise plan. You might have somebody who behavior activation works better for versus something like acceptance and mindfulness or cognitive disputation. There's really a lot of variety there. And I think that flexibility piece is so important. And this really kind of ties very well into this last point, and really that you can't develop a comprehensive treatment plan or provide long-term care as treatment needs to be completed in 4 to 6 visits. And I realize both of these are pretty loaded aspects because these can be 2 pretty overlapping yet different areas. But let's start off with you cannot develop a comprehensive treatment plan. And I think this is really a big one because for a lot of individuals, they may come, hey, this skill worked really great. Our line of thinking may, what's next? What's next in the treatment process? What's another area that we can start to impact? At the same time, that one skill may have done it. Do they need a complex treatment plan? Maybe not. Maybe this is all they need to self-regulate for a while. Maybe later on they'll come back when they need more services. The great thing is them understanding that you're there. As far as that goes, comprehensive treatment plans, Megan and Will, I'd love to hear your take on that.
Yeah, certainly. I'm a big believer that after a few months of primary care, you learn not to trust your predictions. Sure, we've all had experiences where like, oh man, this person's coming in, this is always a toughie. They come in like, things are great, this is awesome. And then vice versa, like, oh, hey, this person's a slam dunk, everything's great. They come in and something tragic and terrible has happened. So I always question the merit of comprehensive treatment plans on that alone. Certainly, like, we need to have an outline and a game plan for some things, but plan for 1,000 scenarios, and lo and behold, scenario 1001 will be what shows up at your door. That said, I certainly think that just having good comfort and familiarity with your theoretical orientation, whatever it may be, should do 90% of the treatment planning for you. So if you're ACT, understanding that different parts of the hexaplex are going to be what maybe different appointments or conversations lean into, and that outlines a majority of the treatment. So I don't know, I think your orientation should do a majority of it that's based on your contextual interview is where I would go with that.
That's a great point, Will. I really appreciate that because I agree completely. I think the comprehensive treatment plan to me also feels individualistic, for lack of a better word. We're not practicing in isolation, we're practicing in collaboration with our medical providers. And so our plan is one piece of the treatment quote unquote, the care that the patient is receiving in the clinic anyway, right? So I think that's the other part that I always keep in mind. And even when I'm doing chart reviews, when I'm going to go see someone, I'm looking at interactions with our team with behavioral health, right? So that I know what's been happening there, but also what's been happening on the medical side and what's going on in the medical notes as well. Part of that can be the referral question, but part of it also is, oh, they saw their doctor a couple of weeks ago, and the last time we saw them was like 6 or 7 months ago. What do we know now, right? What's been happening? What's going on in their life now? So that's something that I always keep in mind, is that my note, my documentation is an augment to the care that they're receiving, right? It's not the only thing that they're getting as well. I don't know if you want me to go on to the second half, Corey, with the 4 to 6.
Yeah, that would be fine, because I think that ties into this first part pretty well.
Correct. The 4 to 6 visits part is one I personally feel really lucky and happy that I work in a place where I don't have to count the number of visits somebody's had, and I don't have to have that conversation ever with the patient of, well, we've seen you 4 times, so this is our last time, sorry, goodbye. We don't have to do that, and that makes me really happy that we can just be flexible. We see people for episodes of care, right? We see them for now because something is happening, something acute, and then we may not see them for a while. I just had that happen yesterday with a patient that said that she had found our conversations to be really helpful. We'd had, I think, 2 visits in the last month and a half. And she said, you know what, I think I'm doing better. So I don't want to schedule a follow-up, and I'll reach out to you. And that's like the second or third time that she's done that in the past 2 years. And then she'll call in when things are not feeling great again. And then we have a few visits and we go from there. So we had talked at some point about whether she wanted to get a step up with a therapist in the community, but she was like, that doesn't feel as useful. I don't think I need that. I don't need to see somebody all the time. I just need to know that there's somebody there when something does come up, you know? And so that was the way that we've done that as well.
Yeah, I mean, Megan, I think that's a wonderful environment to be working in. I definitely do, to where you can focus more on continuity of care as compared to, these are the limitations that I have, and you have this many visits, and because really that also shows too, that can reinforce maybe some of those ideas they've developed. Well, if I don't show improvement in this quick amount of time, then like the person's just going to give up on me like everybody else. You know, and I think that's an area too that sometimes we run into in primary care. We have somebody who maybe has a complex history of mental health treatment or some sort of other treatment, and has had providers they've worked with who at a certain point, they're like, well, this is all I can see you, like, you know, this is not, you're not making any more progress. I don't see what the point of this is here. When in the work that we're doing, it can be very different. You know, it has a very different feel to it. And it's more, hey, we're consultants. We're here if you need us. You know, I'm wondering if there's anyone on this call who maybe has that visit limitation of that 4 to 6 visits, or maybe has that cap, and what they've done to either work with that, work around it, or make the most of it.
We have one of our pediatric practices has a cap on the number of sessions. The remaining practices just have an approximation of what is brief. And I have to say it worked well for this practice, because it took the pressure away a little bit for the BHCs and falling into the pressures of all patients, providers, whoever had a say on when to extend or not, when they have huge volume of patients that need to be seen and only limited resources. It also made possible for them to develop a very good plan for starting the conversation early, for coordination of care as well, for referrals to the community. So even though I agree with everything that has been said here, I also see the positive pieces depending on how you use it.
Yeah, if I can add on to that, Maria, I am in a situation right now, again, it's very co-located what we're doing right now. but we only have 2 providers and we have a wait list of like 60 people right now. And so there's no rule that says we can only provide so many sessions, but there's a lot of pressure to make people better so they can move on and get others in or not see them as often or whatever that might be. And I could see how helping our patients have a shift in their mindset of how can we help you right now for 4 to 6 sessions, go practice it for a while, then come back to me and we'll try it again, could provide more space and access to care in our situation of what we have going on right now. And I can think of a patient that I have who had seen a therapist, the same therapist for 10 years in the past and was going on a regular basis for 10 years. And to me, that says, oh my gosh, what was that therapist doing with you? Did y'all do anything productive and helpful? Because my job is to work myself out of a job. And so I could see how having some kind of limit on there could maybe provide opportunity for more access, but it's tricky and I'm sure it depends on every situation.
I just wanted to, appreciating all these comments, I wanted to make a plug for people tuning into the CFHA podcast that's Enough is Enough, which is targeted treatments. And I think it just does a really nice job, one, sort of beginning to switch our language from saying brief treatment to targeted treatment. I think that's more descriptive of what we do in primary care. Anyway, so those are some things on my mind as I'm listening to this.
Yeah, I mean, I appreciate the quick plug. You know, in addition to that, I think those are really great points. It's how we make the most of the time. You know, how can we best use the time? And if whether we're at some sort of practice or whether it's integrated co-located care, and there's a huge wait list, absolutely. You know, this is population health. We want to have the greatest impact for the most people. You know, and so sometimes we have to have these boundaries set so that way we can provide the most care as possible. You know, and again, I think it's a great point that in some settings it works better than others. You know, hands down. You know, it's a luxury to be able to have the flexibility to see people for a long period of time. At the same time, as Will, you pointed out, we may not get that. We may have to act like this is the single visit we get with this person. Let's have the most profound impact as possible. You know, and I think that's a really good point. So again, flexibility. It all boils down to flexibility in the end. Are we going to see this person 2 weeks from now, or is it going to be 6 months from now? You know, and that takes a lot of flexibility and also openness to addressing new challenges that as they arise for the patients we work with, but also maybe the practice we work in as well. All right, I want to make a little bit of time because I know we're going to probably wrap up in about the next 10 minutes here. So training myths, and I think this is a big one. And I know for the training program that I had been part of, this was a lot of the pushback that I had received from individuals who didn't quite understand the model. You know, and I think this first point is a really big one for individuals who maybe focus more on evidence-based treatments. I like the targeted treatment approach. You know, I think that's really good and gives a nice clear definition, but this evidence-based aspect comes up a lot too. And this is not real evidence-based therapy, or it doesn't apply to any other setting. This wouldn't work anywhere else. Again, my own confirmation bias, my own mind saying right now, it's like, come on, like these skills that people learn, they're really effective. They overlap maybe with what you would see in specialty mental health, hands down. And in some cases, I would say they can be more powerful, you know, especially when they're supported by various members of the care team. Megan, Will, what are your thoughts on this?
Well, go ahead, Will. Do you want to go?
You got it. Go ahead.
Okay. I think this is definitely one I've heard many times. In fact, when I took my own licensure exam 14 years ago in Wisconsin, we still had an oral component to the exam and I had to go before the board and mostly spent my whole time talking about and defending my postdoc in PCBH, which was felt like a pretty high stakes time to explain the whole model and justify the work that I'd done for the past year. Luckily I was successful and I got my license, so yay. But I think, you know, even though that was a while ago and that it was so new at that point in the state, there's still a lot of this residual, right? That people are still trying to wrap their heads around what people are learning. What I hear consistently from the trainees that I work with is the work that they're doing in primary care is it's harder, than what they're doing in more of a specialty outpatient setting. It's not only just the fast pace, but there's more intensity. The difference in the cases, that because we're working as generalists, you're seeing so many different things, can be a little overwhelming at times as well. But there's definitely more than ample time and opportunity to practice all of the skills that you need to be able to be an effective therapist in whatever setting you want to go into. And if you're able to do the work well in primary care, you're going to be able to practice in a lot of different places because those skills are going to transfer over to many different things.
Yeah, I love what you're saying about universalizing and generalizing out. So the geeky research by Bruce Wampole, the great psychotherapy debate, like what are the common ingredients that make any therapy work? Connection between the two people, that the client or patient believes in the game plan, and that the clinician has a game plan. So we already talked about treatment plans, and obviously those three common ingredients that make therapy work are certainly replicable in a primary care setting. So I wouldn't see any reason why you could say that it's not evidence-based when those things are not contingent upon the setting that it's in. So I certainly think that the work we do does apply to other treatment settings. And Megan, to your point about the difference and difficulty, what I say is the challenges are different. They're less striking in private practice. I have 45 minutes of uninterrupted time for every person that comes in the door. So that is certainly a lot easier than having 5 warm handoffs at once and my person waiting in the waiting room, and then, a colleague asking me for like a consultation and, just all the stuff that happens. And so, yeah, the trade-off again being, I see 5 people a day, and that's a busy day here compared to my colleagues. And so we were saying about maybe why it's hard to get people out of the private practice sector. Yeah, the broadness and generalist nature for sure. A lot of my colleagues say, oh, but I don't know how to talk about smoking cessation. Or secondly, like my busiest day ever in primary care is 15 people in one day. Like, oh my gosh, why the hell would you do that? And I was like, it was fun, it was invigorating, draining as heck, but like I loved it. And so, yes, all that to say that what we do certainly can apply to other settings and is evidence-based.
Yeah, I was going to say too, just to tag on to that, Megan, it's interesting. So my initial training was in behavioral health consultation. And so I transitioned, I work in a pediatric burn care environment now. And it's interesting because it's very different, very challenging, but a lot of the skills that I have carried over very well. And sometimes I get asked to do really brief crisis management for outpatient consultation visits, and it's that flexibility has served me very well, versus when I talk about these kind of different experiences I have with others, like they're like, you do all that? Like, is that even possible? And I'm like, it is, and that's kind of the wonderful nature about working and training in primary care, is that flexibility you develop is it's so great, because, you're not going to get that in most other places. And I think, Will, you bring up a good point. Whenever you explain this to maybe individuals who work within that 50-minute capacity, you do get a few looks your way. You're like, what are you doing? Like, how is that even, how can you do that in 30 minutes? And I think that speaks to the unique nature of this work. Also the rapport building aspect. Will, you touched on this a little bit as well, that this isn't enough time to build rapport, and I think just what comes to mind for me is the contextual interview, or having a good brief clinical interview where a person really does feel heard, and you're really showing that you empathize with them and can really have some good options for them or some ideas to work with them. I do want to touch on, because I know we're kind of running a little low on time. The last thing I think would be really important to touch on is personal fulfillment. I think that's a huge one. Megan, anyone else on the call? I would love to hear just about this aspect for you.
Yeah, I'm happy to touch on this. I have already mentioned it before, but I love what I do. And I was so happy when I found it, because it was like what I'd been searching for. And I was like, this is it. This is great. it's immensely fulfilling. And I also think that it's not going to be the right fit for everybody. And that's also okay. You know, that's why we have different kinds of practice that exist, right? So, okay, that's great. I have seen so many patients make amazing improvements over time as well. So I definitely think that that's, you know, seeing people over the lifespan, you really get to see how they grow and change. And that's a fun and wonderful thing as well.
I think this one actually summarizes the rest of the prejudices, assumptions, or whatever we want to call it, what you have been presenting. I think this is a comment probably from, could be someone who doesn't think any of the other things are possible. So I was wondering through your discussion today, how much of this is our own colleagues who don't see this work possible, or I don't know what other adjectives to use, not to be using assumptions myself, but how much work has to be done at that front. That all these are comments that we have heard from our own colleagues, not from people outside the field, or not even by the PCPs, is behavioral health clinicians.
I would encourage anybody who's feeling like down or needs a pick-me-up to go read one of Dave Bowman's emails, the ones that he sends out with the stories. I think that's what he calls them, PCBH stories. And man, when I'm having a rough day, I just go find one of his that I haven't had time to read yet. And it just makes it so much better because it's just such a good reminder of all the things that can come up. And I know for me, when I was doing truly integrated care, some days, you know, you'd see 8 patients and it was like, man, am I really doing anything today? And then you have that last one who like needed it. And you think, oh my goodness, I'm so glad I was available. So glad I'm here. This is why I do what I do. And it's just so fulfilling. But yeah, Megan, I found my people when I found this. So I can relate to that. You just have to find the right fit for you. And maybe that's not for everybody, but sure fills up my cup.
And I would add, as far as finding the work fulfilling, I think ultimately one of my greatest values and goals is to be as good at my craft as I can be. And I think without a doubt, primary care certainly pushed me in every direction, being good with time management, learning a bunch of broad skills, being good with couples, families, individuals, being able to improvise, everything. So I think that's what I found probably most fulfilling, was how much it made me work hard to get better at what I do. So that's why I loved it.
Well, you know, I really want to thank everyone for joining us today. And I think that's a good note for us to finish up on. You know, if this work wasn't fulfilling to us, we wouldn't be here, we wouldn't be having these conversations, and we wouldn't be trying to do the most we can for the patients we work with. You know, so Megan, Will, thank you again for joining us today. You know, sharing your great insights. Thank you to everyone who's been on the call, whether you participated or listened. I hope that you can take away something positive from this experience. Again, these community conversations are just kind of where we can come together and talk about some of these ideas and also support each other. I do think as well that we will probably have another one of these kind of myths of PCBH calls probably in the future, just because it seems to be a really popular topic for people. So again, thank you everyone for joining us. I hope you have a great day and we'll see you soon.
Bye, thank you.
Thank you, everyone. Have a great day.
Thanks, everyone. Great to see everyone.